Happy Friday, everybody. It is a gorgeous, nice and chilly morning here in not sunny Arizona. It might rain today. Rained over the past few days on and off. But we got 3 procedures lined up today. We have a stellate ganglion block, and then we have 2 PRP procedures. The first one is going to be for low back, knee and ankle, and the second one is for low back and the thoracic spine. So that's our day. We're going to get into it. Let's get it. Happy Friday, everybody. What a day we had here. So we are just wrapping up. It's the end of the day, just after 6 o'clock here, Fridays at RP. So we had 3 procedures today. First procedure was a stellate ganglion block. Second and third procedures were PRP procedures with the second one we added in a placental matrix product. And then our third procedure, just PRP, treating a few things. But I'm going to talk through the procedures we did today and then highlight on a few different things that kind of came up during them. Our first procedure of the day was a stellate ganglion block, which is where we go into the front side of the neck and we basically use a local anesthetic. We use ropivacaine and we block the cervical sympathetic chain and also the stellate ganglion in order to help reduce basically the brain's communication down to the adrenal glands, which is part of the sympathetic nervous system, which is going to contribute to some anxiety, PTSD, things like that, chronic pain as well. The sympathetic nervous system involved in that. But with this patient, we actually did it for a very interesting approach. So this patient was diagnosed as a type II diabetic and at one point was on insulin. However, over the last kind of year and a half, we here at the clinic worked to get him off the insulin and because he was never actually insulin dependent, he was actually inappropriately put on insulin. But we got him on a continuous glucose monitor, and the patterns that we started to see were really fascinating, such that his blood glucose would skyrocket anytime he had stress, whether it was family stress, whether it was personal stress, work stress, health stress, whatever it was. When he was under a lot of stress, his blood glucose would really start to rise, even if he didn't change his eating patterns. And so when he also would go on vacation or go camping or just, take time away from his normal everyday life, his blood sugars would improve so much. And so we actually ended up having a conversation about trying the stellate ganglion block to see if we could help modulate his nervous system, the sympathetic nervous system, to the point where maybe he didn't have as great of a jump in his blood sugars when he was under stress, because his body would physically perceive less stress for the stressors that were coming at him. This was obviously an experimental procedure in the sense that there wasn't really any literature that I could find on this type of, on why to do this approach. Obviously there's a lot of literature on the stellate ganglion block, but not really anything on using it for this application. And so we are going to repeat the procedure in just over 10 days. And then we are going to track this patient over the next 3 months with his continuous glucose monitor to see if we notice any trends in his stress and his blood sugars from that. So that was our first procedure. Our second procedure of the day, a patient who had been skiing and injured himself many years ago, injured his low back, and then just a few years ago was skiing again and injured his thoracic spine. And so we did our physical exam obviously a few weeks ago, but one of the things that really came up during our procedure today, so the structures we treated, we did the supraspinous and interspinous ligaments in both the thoracic and the lumbar region. We also did an erector spinae plane hydrodissection in the thoracic region, treated the thoracic facets, and then in the low back, treated some of the supporting ligaments around the SI joint on the left, and basically all the facet joints from L3-4 all the way down to L5-S1 and the supporting multifidi. And so with that procedure, what was really interesting was I didn't personally expect his pain recreation to come from these supraspinous and interspinous ligaments when we were treating them. The physical exam in the thoracic spine had suggested that it was more so the facet joints that were contributing to his left-sided pain in between his shoulder blades. And but because he did have some mild tenderness over top of the spinous processes, we treated the supraspinous and interspinous ligaments. When we were treating those, the patient reported that he was having some of the left-sided familiar pain between the spine and the shoulder blade, which again, I didn't expect because I would have expected it to come from the facet joints. And so what I want to really talk about with this is why it's so important for when we're doing procedures to be communicating with the patients to try and have an understanding of what they're going through during these injections so that they can give us feedback. Anytime we do these procedures, I'm always making sure we have a little bit of, whether it's PRP, whether it's stem cells, whether it's prolotherapy, we're always making sure we have a little bit of extra solution set aside in case we get to an area that we didn't expect would cause recreate the patient's pain. So that way we can make sure we put a little bit extra in that area, because if we're recreating pain with our needle, we are presuming that those tissues are part of the pain that they're having day to day. Because if you have damaged tissue that the brain is sensing pain signals from, and then you put a needle into it and push some fluid into it, which stretches some of the receptors in the area that are going to be sensitive to pressure and things like that, your brain can then perceive that same pain again because it's the same tissues. And so that's why it's always super important for us to try to recreate pain during these procedures, but understanding that even still, we don't always recreate pain, even in the patients who get better. There's still a small subset of patients that we don't recreate their pain during the procedure, and they still have really great outcomes. But again, it's always something that we are striving for. And then our last procedure of the day was PRP for a patient who had had a discectomy back in 2019, but was still suffering from chronic low back pain. His physical exam indicated that he might still have some pain coming from the lower discs. His discectomy was up a bit higher, L2-3, but he might have some pain coming from the lower discs. And so we did a caudal epidural to see if we could help bathe those lower discs and get some healing there. And then also the facet joints, the supraspinous and interspinous ligaments as well. And then some of the overlying nerves, the cluneal nerves, the mediocutaneous branch of the dorsal rami. So we treated all those and then flipped them, and then we treated his knee and his ankle. Now, on physical exam for his knee, he had Osgood Schlatter's as a kid, and but that didn't really seem to bother him much anymore. The patellar tendon was not really tender to palpation. The tibial tuberosity, where the patellar tendon is going to attach and where you get osteoslaughter, is no longer tender to palpation. So we didn't really think that we were going to do anything in regards to the patellar tendon. The physical exam showed that most of his pain was likely coming from chondromalacia patella, which is where the underside of the kneecap, where there's cartilage, there can be some inflammation and a little bit of degeneration. And then some saphenous nerve involvement. And so we hydrodissected the saphenous nerve and treated that. We then treated inside the knee joint to bathe the cartilage on the backside of the patella. And then I went to go treat the infrapatellar fat pad, just because I'm such a huge believer in the infrapatellar fat pad contributing to the healing of joints, or the knee joint specifically. That when we scanned his patellar tendon, he actually had a pretty significant tear in his patellar tendon. Now, at this point, we have to step back to understand that maybe this is not painful for him, because again, our physical exam didn't really suggest that the patellar tendon was involved in his pain. However, we also have to understand that sometimes the physical exam might mislead us. Sometimes in really athletic patients, we might not get the full picture because the tissues are so used to being moved, manipulated, things like that, that we don't always elicit pain from certain structures. And we also have to think about the long-term aspect. So if you have a large tear in a tendon, that tendon is going to be compromised, obviously. And over time, that could progress to where it becomes painful, or where it could result in a further tear that could be problematic. And so because of that, we made a game time decision with the patient to add in and inject the patellar tendon with PRP inside that tear to hopefully help that tear heal, which I'll be excited to follow that and track that. And interestingly, when we did those injections into that, it did create some familiar pain for the patient. Again, going back to the earlier discussion of recreating patients' pain, this was important for us because it was something that didn't show in the physical exam. And if I didn't do ultrasound guidance for my imaging for my injections, then I wouldn't have known that this tear was there, because it also did not show up on his MRI, which is rather interesting because it was a pretty significant tear. But that is what we ended up doing with him. We put a little bit extra PRP and some BPC into that tear to try and help that heal. That was our Friday, everybody. Thank you all for sticking around. I hope you like the new footage. We got the GoPro, we got the camera going down, looking, everything like that. So if you like that, please, or anything in this, please leave a comment, say thanks. I'd like to say hi. I would like to say hi. You don't have to say hi. But yeah, thanks for tuning in, everybody, and we will see you next time.